So this is Brian Mimm, and it's my pleasure this month to introduce our speaker. Lauren Brookman-Frazee is a clinical psychologist who's had a good amount of UC California affiliations, finishing her PhD at UC Santa Barbara and then completing a postdoc down at UC San Diego, where she now has a faculty position and serves as the Associate Director of CARSIC, the Child and Adolescent Services Research Center. Worked with Greg Ahrens and others in what is a strong and still growing group of implementation scientists in child and adolescent health, and is speaking to us today about sustainment. So, Lauren, thanks again for agreeing to speak.
Thank you very much for having me. I just want to acknowledge that this study that I'll be talking about is a joint effort between UCSD and UCLA. We'll be discussing an R1 study funded by NIMH that's focused on measuring the sustainment of multiple evidence-based practices that are fiscally mandated in mental health services in LA County. Lau and I are the PIs of this study. I do want to acknowledge that the LA-based team are currently on lockdown right now, so they are in on this call, but we're thinking of them. Go to the next slide. So I'll really focus most of the time today on providing an overview of the study context and the study methods, and then provide some initial findings to illustrate the design of the study and how we're conceptualizing. So for KEEPS study, we are applying the EBPs implementation framework that was conceptualized by one of our co-investigators, Greg Ahrens. The EBPs framework highlights multiple phases of implementation as well as the multi-level context of implementation. So most of the research to date, or much of the research to date, has really focused on the initial implementation of one EBP, or evidence-based practice intervention, and was implemented either at the therapist level through training or the organizational level. There's less known about how interventions are sustained after the initial implementation and the factors that are associated with sustainment outcomes. There's less known about system-driven and system-level implementation efforts. These are increasingly common in the context of routine evidence-based practice implementation. So just for example, recently there have been state and local system-driven EBP efforts in Washington State, New York State, the city of Philadelphia, as well as LA County, which is the focus of the study. What's the unique aspects of kind of a system-driven implementation context? But one of them is that the system-driven efforts typically involve the installment of multiple EBPs to cover the range of problem types of the consumers that are receiving care. And that's them. So for KEEPS study aims to address two gaps in the literature by studying the sustainment of multiple EBPs in a mental health system-driven implementation effort. So the context of this study and the context of this system, this mental health system effort, it was really initiated and influenced by the ballot initiative in California, Proposition 63, or the Mental Health Service Act. This was a proposition that passed in 2004 in California. So for those of you who are not from California or may not remember this process, Prop 63 continues to levy a 1% tax on personal income over $1 million with the purpose of expanding funding for mental health services through the Mental Health Service Act involves multiple programs and initiatives, one of which is the Prevention and Early Intervention Program, which aims to intervene earlier in the course of mental illness. So in this context, each of California's counties and a few individual cities, they developed their own Mental Health Service Act plan that was submitted to the state and approved by the state, which all include plans for how the Prevention and Early Intervention Fund would be spent and implemented. Slide. So the focus study is really about the PEI, or Prevention and Early Intervention, transformation within Los Angeles County, within the Los Angeles County Department of Mental Health. So the DMH, the Los Angeles County Department of Mental Health, is the largest county-operated mental health department in the U.S. It operates 75 sites and has almost 300 agencies that are contracted to deliver mental health services. Within those contracted agencies, about 120 of them deliver mental health services to children, which is the specific client population that we're interested in this study. Just to illustrate the size of LA County, all of the states in blue on the map on this slide have a population that's smaller than the population of LA County. On average, LA County Department of Mental Health serves about more than 250,000 county residents of all ages. And these clients are an ethnically diverse population that live both in urban and rural areas. Next slide. So we are applying the EBPs framework and phases to map the PEI transformation timeline in LA counties. So in kind of exploration phase that's part of the EBPs framework, LA County was, like other counties, was responsible for conducting a comprehensive needs assessment of the population served or underserved or not, and, within its department, and submit a plan for how funds would be used. LA elected to utilize the PEI funds to promote the use of evidence-based practices, intervene earlier in the course of mental illness. So as part of the exploration phase, and through stakeholder involvement in a needs assessment, the mental health identified evidence-based practices, promising practice, and community-defined evidence that were identified to meet the needs of the patient population. The department also established an implementation unit, a PEI implementation unit, that was responsible for initiating this transformation. So a county's PEI plan was approved in 2009. So in August, this transformation was really initiated and launched. It involved restricting the reimbursement for PEI funds to an array of 52 different interventions that were identified in the planning process, and that was for both child and adult. So in 2010, the agencies that were contracted with the Department of Mental Health were provided to receive reimbursements for specific processes or practices. So this financial context is really important here. This occurred during a state budget shortfall or budget crisis, really, that such that the opportunity for new funding was really important for community-based organizations that were facing fiscal problems. The agency submitted training plans to scale up the delivery of practices, and DMH selected 6 child-focused practices in which they supported the implementation. So that meant that they organized the trainings. They provided funding for the trainings and for ongoing consultation. So it was really, this process was centralized with DMH for 6 practices. Next slide. So the details of the practices that were initially supported by DMH, but I'll just highlight that they varied in the target age range, the problem focus, the setting of the delivery of the intervention, and in the therapist training protocol. So next slide. So started in April 2010, and these trainings were really large scale. It involved trainings, really thousands of therapists in multiple practices, often in multiple practices. And right after the trainings began, then began delivering and billing for these practices that were approved by their agencies. So what I like here is that this was a very fast process. So training and then implementation occurred really together over a short amount of time. Next slide. Initial implementation really occurred between 2010 and 2012. 2013 really marks the beginning of the sustainment phase of the PI transformation. So the Department of Mental Health efforts really shifted from ramping up these practices and getting lots of people trained at one time to really ongoing training and ongoing delivery of these practices. There's also a shift in focus from the county, DMH's perspective on focusing on compliance with PEI guidelines. It involves required outcome monitoring and ensuring that those who are eligible for specific practices are those that are receiving those practices. So sustainment phase is really where the 4KEEPS study comes in. Next slide. So 4KEEPS is a neutral observational study investigating the sustainment of original 6 practices for children which DMH provided implementation support. We say neutral in that our research group was not involved in the implementation of any of these 6 practices, and that we're not part of the development of these 6 practices. The overall objectives of the study are to characterize sustainment outcomes and identify inner context, so agency and therapist level factors that predict the sustained reach and use of these multiple evidence-based practices. Next slide. So we involve multiple sources of data, mixed quantitative and qualitative, both original data collection and secondary analyses of existing DMH data and source documents. Almost all of these data sources were assessing sustainment outcomes, which is whether these practices continue to be used, whether and how these practices continue to be used, as well as in-context factors that are potentially associated with ongoing use. So the data extracted from DMH really covers all of the agencies that were impacted by this PEI transformation. The first source of quantitative data from DMH is that we are extracting administrative claims for almost 8 years of for these 6 practices. And then we also extracted documents that detail site visits that DMH conducted at at over 100 agencies during the initial implementation period, which is a source of qualitative data collection for us. So our original data collection is gathered from, it includes surveys, semi-structured interviews, and session data collection from both a representative sample of agencies as well as a smaller subset in which we're conducting an in-depth study that involves semi-structured interviews and session data collection. Next slide. this is a timeline that we often show to agencies that are contracted with CMH, just to show them where we are in our original data collection. So at this point, we have collected our first large-scale survey and some supplemental follow-up surveys with some targeted questions. And we're in the process of conducting an in-depth study and subsample of agencies that will continue through next year, at a point where we'll be conducting a second large-scale survey. So to date, we have collected survey data from program managers and therapists in over 50 agencies, and we anticipate having data from 20 programs within these agencies in our in-depth subsample. Next slide. So to spend some time talking about how we are defining sustainment, because there's lots of different approaches to defining sustainment. We are really using multiple complementary measures and constructs of sustainment in the current study. So at the system level, the highest level, we're using claims data to characterize both the volume and penetration of each practice at multiple levels. So that we're looking at the reach of practices, of the 6 practices at the unit of service level, any clients are impacted by these services, therapists, and agency level. We decided to index both penetration and volume, as we did an important limitation of indexing a penetration ratio alone is that it doesn't track the absolute scale of implementation that really changed significantly over the course of our study time frame. Finally, when we think about penetration, as we're concerned that the denominators used to calculate the penetration ratios change both over time with workforce and system policies. So for reasons, we also assess the volume of practices addressed by raw units of the number of agencies, therapists, children, and units of services to characterize the scale of implementation. And more on that in a moment. In addition to using administrative data, we also wanted to measure how the practices are being delivered when they are used. So we are measuring the extent to which therapists report delivering each practice using strategies expected in the EBP protocol, and we're referring to this as EBP Concordant, which I'll get into. So I'll start by providing a little bit more depth into our claims data. Slide. So we extracted claim data for claims that were collected over the first 19 fiscal quarters of PEI transformation. And therapists make a claim for a service. They actually specify which practice they are claiming for. That allows us to analyze the use of individual practices over time. Our starting point, what we started with was over 3 million claims for just those 6 practices that we were interested in. Almost 2.5 million of these claims were for psychotherapy claims, which is really our focus. And these represent claims for over 87,000 children, unique children, that were served by 8,500 providers in 94 different agencies. So it just illustrates the volume of claims data that we'll have. And then we will do we're continuing to extract these data over time for our first 19 fiscal quarters. So kind of broadly looking at the cumulative number of claims, not broken down over time, but the cumulative number of claims, we see that there's really substantial variability in volume of each practice of claims, such that MAP has the largest number of claims over these 19 fiscal quarters, with over almost 1 million claims or units of service, where it has close to 3,000 units of service. And this pattern is consistent when we aggregate to the therapist and to the agency level. The cumulative number doesn't show how patterns change over time. So this figure, I'm not going to get into the in-depth details of these figures. But what these figures show are the raw number of claims, number of children with more than one claim, the number of therapists, and the number of agencies claiming for each fiscal quarter. And then we also have the total number of claims, children, therapists, and agencies that's represented by the gray solid line. So really what these data show is that there's rapid increase in the raw volume and leveling off. So it highlights that there's a rapid impact of training these providers in a practice and restricting reimbursement for these practices. So I mentioned that ramp up kind of happened overnight, and I think our claims data illustrates that perspective. Next slide. So then looked at the gross penetration or reach over time. Gross penetration was calculated at multiple levels as before, as indicated by the number of psychotherapy claims, for example, per practice, divided by the total volume of claims across practices. Similarly, the number of children with at least one psychotherapy claim to each practice of fiscal quarter was divided by the total number of unique children receiving any of the 6 practices. So these data show and complement the volume data is that some practices, so in the initial period, some practices ramped up more quickly than others during the initial ramp-up period. Then, after about 2 years, there was some reordering of the practice penetration, clear stabilization, where MAP, focus CBT, and seeking safety consistently had the highest penetration. Consistent when we look cumulatively over the number of claims for these practices. Now, I wanted to with our DMH partners to really think about, well, what are the characteristics of the higher versus lower penetration practices that help us understand which practices may be, higher reach and volume in these large-scale system efforts. So higher penetration practices, surprisingly, those practices really apply to a broader age range of clients, can be delivered in multiple service settings, and they address the common, or they can address the most common presenting problem in this population, which is trauma exposure. And we also see that MAP covers a range of other presenting problems as well. As far as the implementation characteristics of these practices, both MAP and seeking safety, 2 of the higher penetration practices, do have a train-the-trainer capacity, which allows agencies to have a trainer within their agency and to train new providers or new clinicians as they come along, so they can really develop a capacity within their agencies. Additionally, seeking safety was one of the practices that had the least requirements for training in order to be eligible to bill. So seeking safety therapists could bill for that practice after attending a one-day workshop. Conversely, the lower penetration practices apply to a narrower age range of clients. It's a more specified setting or group format. So 2 of those practices were group-based practices. CBITs delivered in the schools. And practices were also caregiver-directed, specific age ranges. Related to implementation characteristics or requirements of these practices. There were additional requirements, at least for CBITs, since it was delivered in schools, the agencies were required to, or often needed to obtain MOAs between the school and programs, so it added an additional level of requirements to deliver that practice. Really just provide some information about the characteristics of practices that may have higher or lower penetration. So as far as, claims data really have the advantage of looking very broadly at which practices are most used and how they change, their use changes and stabilizes over time. What don't tell us is how these practices are being delivered when they are used. And so for this reason, we use a second construct of sustainment, which we refer to as EBP concordant care. Again, referring to the degree to which a therapist practice resolves the essential strategies within a given EB for specific focus, problem focus. Next slide. Talk a little bit about how we got to the construct of EBP concordant care. We actually started with the construct of fidelity, and using fidelity as one of our key sustainment outcomes. And when we think about fidelity, we think about the degree to which an intervention is delivered as intended by a program developer. And ideally, therapists continue to deliver evidence-based practices with a high degree of fidelity, functional implementation into the sustainment phase. But we had some concerns about the feasibility and appropriateness of using traditional fidelity measures in our study. For example, direct observation is really often the gold standard in evaluating treatment fidelity in controlled trials, but it's clearly not feasible in large-scale implementation of multiple evidence-based practices. Measuring fidelity across interventions that may vary in content and focus, it really represents a major challenge that has to be overcome when there's multiple EBPs adopted. So therefore, for these reasons, we assess a related construct to characterize sustained use, which is EBP concordant care. And this term really comes from the term guideline concordant care, which has been used in clinical quality literature. So we decided, and we made the decision to depart from protocol-specific fidelity that includes features specific to manualized protocols but don't necessarily generalize, to focus on strategies that are common across a family of treatments that are shown to be effective for ameliorating mental health conditions. So I'll illustrate what we mean by that in a moment. Next slide. So one of the important contributions that the 4KEEPS study, what we think is making, is the development of a measure of EBP concordant care. So we refer to as the ECCA, the EBP concordant care assessment. The ECCA will provide a common metric that can be applied to assess the extent to which a therapist does practice essential in major mental health targets: anxiety, depression, conduct problems, and trauma. And this measure is designed to be completed by therapists. So a therapist report measure for concerns about feasibility and efficiency. But we're also validating these therapist reports against observer ratings. So we've really embarked on a multi-step process to develop this ECCA assessment. So we started with reviewing existing practice inventories, such as the TPOCs that was used for an existing study of developed by Rice McLeod and adapted by Anne Garland and her group to characterize usual care psychotherapy. Then adapted and selected strategies and developed a practice expert survey where we collected data from practice experts from those 6 practices to have them rate how essential or interfering each of the individual strategies were to their practice. Then we looked at those strategies that were rated as essential by practice experts to the items for our initial self-report. And then we've collected data, and I'll get into that, from a large sample of therapists using our first version. We're going to examine the properties of the therapist report, ECCA. We're collecting data currently to validate this therapist report with observational coding, and then we'll be finalizing and refining the measure as we go. Next. So what the current ECCA looks like is that we have different online versions. So we have a session-level version where therapists report what strategies they used in a given session, and then this is where we also have a corresponding observer rating. Then we have a bi-monthly version where the therapists report on what strategies they used over the past 2 months. It currently includes 38 different content and techniques, content referring to the substance or issue that's being addressed in an intervention, and the techniques is really how the content is being conveyed. The data that we've collected to date on the ECCA is that we have collected a bi-monthly ECCA from over 700 therapists from over 50 agencies. And then we also have our subsample, and we're revalidating the and therapist report versions. And we've currently obtained session data from 459 conducted by 71 therapists. We've also coded 80 of those sessions for Concordant. Next slide. Preliminary findings from the ECCA do support its use and utility. First of all, I think that it's important that it does appear to be feasible to use. So when we look at the time that therapists, from the time they open their online survey to when they submit it, the modal time for submission was 4 minutes, which is really important when we're thinking about efficient methods for assessing practice. We've developed some initial composites that really combine the ratings for strategies in each of our 4 EBP targets, and we're finding high internal consistency. What you see is some evidence of discriminant validity where significant difference in our composites based on what EBP type is delivered. So basically, if a therapist reports that they're delivering a conduct or a practice, their composite scores on those composites are higher than for other EBP targets. So it shows some discrimination. Related to the construct validity, we've submitted our item response theory analyses, and those items that have higher item difficulty do appear to be those versus low item difficulty do appear to be those strategies that really reflect high integrity EBP concordant care. So clearly, this is just one example. Ignore differential reinforcement of other behaviors has higher item difficulty estimates than praise, and that clinically makes sense, and so it does support some of the construct validity. Next slide. We are finding high concordance between the session and bi-monthly version, and so it appears that both of these may be options depending what the needs are in the future use of these measures. I'm also starting to, our concordance data are really just starting right now because we have so few sessions for both therapist reports and observer reports. But based on a small set of sessions where we have both reporters, what we're finding is that there's greater concordance for the strategies that the therapists report that they're using versus those that that are common in the strategy intervention that they're using. Promising and consistent with the literature on therapists report on their own practice, where therapists are reporters when they're talking about strategies, reporting on strategies in which they've been trained. Next. So this is a major effort that we have undergone in developing the ECCA. So our next steps are to finish validating the therapist report ECCA with their observational coding system. We're projecting to have about 1,000 sessions that would have both therapist and observer readings. We'll also start to look at what therapist or organizational factors to be associated with higher EBP concordant care. And then ultimately, our goal is to have an efficient and effective instrument that can be used to characterize sustainment. So we'll be refining our instrumentation based on both concordance analyses, findings, and end user feedback. So therapist, clinical supervisor, feedback on the utility of its use. Next slide. I want to so most of this time talking about our outcomes, so how we're conceptualizing outcomes. I want to get into describing some of the ways that we are characterizing potential determinants of our sustainment outcomes. So in our initial design, we did not propose to examine or measure system-level determinants. And our rationale was that the system level is held constant across agencies and therapists and clients. But we have decided to collect some data on system level because it changes over time to examine how if there's changes in state regulatory requirements or the system adopts new or de-adopts EBPs, how that impacts sustainment of our initial practices of interest. But our major focus on inner context variables, which are at the organizational level and the therapist level. So at the organizational level, we really focused on, what implementation support strategies organizations are putting in place to support practice sustainment, organizational clients, and really the early implementation conditions for those organizations. At the therapist level, we are examining therapist attitudes and what adaptations they make to practice and how those predict sustainment. Next slide. So what we think is a particularly unique context is that when we look at therapists and practice characteristics that facilitate implementation, most of the literature, or much of the literature to date, has really focused on attitudes towards EBPs versus practice as usual. Really, in context, we're looking at attitudes towards effective practice in comparison to other practices that are used within the system and within the same agency and often within the same therapist. So that allows us to parse that variance in attitudes that are related to practice versus therapist characteristics. So our qualitative analysis data collection is ongoing, but we have completed our initial quantitative data collection as part of our large-scale survey. We have 790 therapists that have completed a survey that includes the bi-monthly ECCA if they had delivered the practice recently, but then also measures of attitudes and perceptions of climate and more. Next slide. So approach measuring attitudes in two different ways. Looking at practice-specific attitudes as general attitudes towards evidence-based practices. So it's this openness and perceptions of divergence more generally, but it's not practice-specific. What we're initially seeing is that there are practice differences in attitudes. So we find that the most positive attitudes or practice that therapists report most positive attitudes toward is trauma-focused CBT. And the practice where we have still favorable but less favorable attitudes is CBT. Next slide. We've really had to look at how practice characteristics relate to practice-specific attitudes. So went about characterizing our individual practices on a couple different dimensions. Assessing whether there was a narrow age range or a specified age range for a given practice, that there was a prescribed order or content of the delivery, and then related to the implementation requirements is whether or not consultation was required for a given, to learn a given practice. And next slide. What we find is that, interestingly, that there are differences in therapist attitudes by practice characteristics. So there are significantly higher or more positive attitudes towards practice that have a prescribed session content or order than those that don't. And there are more positive attitudes towards practices where consultation is required. The opposite is true when there's a narrower age range of the practice. I think this is important finding because some officials, concerns about evidence-based practices that it was too prescriptive and, may take too much time for training. But what we find is that therapists actually have more positive attitudes towards those practices. Slide. I just want to spend a little bit of time about how we're characterizing their adaptations, because we think this is a potentially important determinant of sustainment, is how therapists are adapting their practices. We're using both quantitative and qualitative methods to characterize adaptations, and we are applying Shannon Wilty-Sturman's adaptation framework, where she conceptualizes adaptations as fidelity consistent or fidelity inconsistent in nature. We're also looking at the reasons that therapists make adaptations. Next slide. So what would overall is that reports may, on average, making higher fidelity consistent than inconsistent adaptations. Next. This slide illustrates this well, is that, again, therapists report more fidelity consistent adaptations than inconsistent, which is good news. And we also find therapists' attitudes towards a practice, they don't predict fidelity consistent adaptations, but they do predict fidelity inconsistent adaptations. Next slide. We do find that from our district qualitative data that there are certain factors that that impact the reasons for adaptations. And so these include culture, developmental level, so a developmental level of a client, for example, relate to omitting certain aspects of a practice. And then we also find that therapists report that crises that come up certainly impact how they present practices, how they modify the presentation of practices. And for the sake of time, we won't go into details about that. But what we're finding is that the reasons for these adaptations appear to be often clinically indicated. Therapists are being thoughtful in the way that they are approaching adaptations. So just to summarize a lot of information that I provided about the study, the size and the scope of the PI transformation really does provide a unique opportunity to examine implementation of multiple EBPs in the system-driven neural laboratory of EBP implementation. We are seeing that sustainment does vary by practice and that the patterns do change over time, such that the patterns that may be evident in kind of structural implementation may be slightly different than what we see in the sustainment phase when practice penetration, for example, really stabilizes. And that we're starting to have some in-depth understanding of the inner context factors that seem to be related to implementation efforts. We see that therapists attitudes do vary by practice, and that they are reporting more extensive fidelity consistent adaptations than fidelity inconsistent adaptations. I'm going to we can go next slide. I'm going to wrap up my discussion of the study now, but just really thank our partners, include the county, LA County, and ACCA, which is an agency that represents the agencies contracted with LA County DMH, and of course the therapists and program leaders who have provided such rich data about their impressions of deputy transformation and impact on their practice. So up, and Brian, we open it up to questions for just a few minutes.
So we have a good minutes or so, according to my watch. So thanks for a great presentation. And I know the chat function is available as well, but all the mics should be open now if you have any questions or comments. And Ibrahim, you can see the chat box and monitor that?
Yeah, I am, yes.
Right. Okay.
Yeah.
Just give it a minute before I give you my questions. So one is sort of the standard, what are some of the generalizable implications? I know that you work largely in the children's mental health area. For those who are working in general medical care delivery, those of us in large systems like Kaiser and others, as well as those interested in community smaller settings, are there some lessons for the study and understanding of sustainment that you see emerging from your work?
Sure. I appreciate the question. I think that one of the things that we've spent a lot of time thinking about is really how do you measure sustainment, and particularly in the context of system-driven efforts. And I think that what this study hopefully will illustrate is that really the multiple methods that are needed to characterize sustainment. Looking at EBP concordant care, without understanding which of these practices continue to be used really only gives a narrow focus on sustainment. But then, of course, just looking at the claims data does not indicate to us how practices are being used. So I think that having multiple levels of measuring sustainment is an important contribution of the study. I think that I articulate explicitly this finding, but I think that what's emerging from our study, especially when we're thinking about attitudes and really our claims data, are that the characteristics of practices are important. So the characteristics of the innovation to be implemented are clearly important. But those characteristics of the practices don't occur in isolation. They occur in combination with specific implementation strategies. And sometimes it's difficult to parse out what's a characteristic of the innovation versus an implementation strategy. But I think that what we're seeing is that they both matter in both how providers feel about practices and how they're being sustained. And so that when we're looking at these large-scale efforts, that looking at both in combination is really important.
Okay, and I think that each of those points I think is very clearly in relatively straightforward to apply them to other domains. In most cases, there are claims and outcomes and other measures that you've described. So, okay, thank you. Other questions, comments from others on the line?
We don't have any questions in the chat box for now.
Okay. Sometimes we have a quiet group. Sometimes we have lots of questions.
I'm happy if there are questions that come up after this webinar. You're welcome to contact me. I'm happy to talk about our center. I covered a lot, but there's a lot more that we're diving into, so I'm happy to have ongoing conversations with folks.
Okay. So another minute in case there are any others. And just another question I had has to do with next steps and what you see as future steps, both in this research agenda for this particular set of programs, but more broadly in terms of research on sustainment.
I think that so next steps of this study are clearly to look at the patterns over time. We'd like to be able to link information that we get from therapists and program managers to the system-level claims data to look at which factors really do predict sustainment at what time part and over time. But we think that where we're going, there's a couple of different directions. First of all, I think that the ECCA has the potential as putting a lot into the development of the ECCA. And it has the potential for use as a quality indicator. And our DMH partners are very interested in how can this measure be used as an index of quality. And so we'll be looking at refining that, and then hopefully in the future looking at how that contributes to child outcomes or client outcomes, so we can kind of narrow down which strategies that therapists may use, what do those serve as quality indicators. I think that there's value broadly in considering use of measures of EBP concordant care that may not be, that may be common across the innovation or the intervention to be delivered. The other piece that I think is important is that I think that we likely will have data on specific implementation strategies and about which are working, with them the agencies are implementing on their own in response to PEI transformation, that I think can help us potentially develop better implementation interventions and that can be tested, because there's a lot of, I think, innovations that are occurring at the agency levels out of necessity in response to the PEI transformation that we'll be able to characterize and test in future research.
I think the opportunity to do that in more natural settings, rather than the artificial things that we too often find ourselves in when we're running interventional experimental studies, strengthens the value. So, Ibrahim, let me turn the mic over to you for the last couple of minutes for any comments or points about evaluation, future sessions, updates that I hope we'll provide soon about the 2017 symposium. But Lauren, thanks again for the excellent presentation, and we appreciate your time.
Thank you.